we know that cauda equina is an awful condition, and it really can wreck lots of young people's lives. It does wreck lots of young people's lives. If you're not, or Bex, I think it is.
Yes.
If Bex isn't familiar already, there are several cauda equina services in the country. I'm familiar with one at St George's Hospital and one at the Royal National Orthopaedic Hospital, and these are sort of super regional centres. So you may find that the Royal National would consider seeing them. They're fantastic at managing some of the long-term pain and urological problems left with cauda equina, people left with cauda equina syndrome have. So it's worth looking at.
So these are people post-surgery where it's been too late and they've got the symptoms remain.
Exactly, exactly. And this is the problem with cauda equina, that it tends to be very sudden onset. Typically we talk about bilateral sciatica with saddle paresthesia, anesthesia, and insensate urinary retention, but it very rarely looks exactly like that every time. It's usually secondary to a large sequestered disc fragment in the lower lumbar spine at 4.5 or 5.1. And for some reason, an acute prolapse that presses on the nerves is much less well tolerated than chronic compression that's built up over time. And it's probably to do with collateralization of the blood supply. If the pressure builds up over time, more collaterals can develop. It's the way I think about it. I don't know if it's correct or not, but and so you get an acute disc prolapse, the nerves are pressed on, and you can be left with permanent dysfunction. The disc recurrence, unfortunately, is a known problem. It occurs in about 1 in 20 patients who have an open microdiscectomy, about the same for endoscopic, maybe slightly less. And in surgery, we try to avoid it by checking within the disc space for any other free fragments, and you can do that through irrigation or manually checking. But occasionally it can happen. The key thing is early recognition of it happening. And you can imagine this is quite tricky because somebody has Cauda Equina Syndrome, so they've got these symptoms. We know that it doesn't always recover, and although we try to operate within 24 hours, that's the sort of the guidance. A lot of patients don't get better. So you take somebody to theatre, you do the surgery, and they don't get better. Is that because more disc has come out, or because they're one of the people that weren't going to get better? And so it's happened in my practice once or twice, not as a consultant actually, but as a trainee, and it's not always as easy to realise why it's happened, and you'll often end up scanning the patient. You'll operate at 5 o'clock the night before, they're not better that night, and you're not sure whether or not it was because more disc has come out, and you scan them the next day in the morning and more disc has come out, and so you have to go back in again. It's not always straightforward.
I think Cauda Equina Syndrome is one of the things that sort of really worries physical therapists, because it's not easy to spot at the sufficiently early stage to make sure it can be dealt with safely. And we've done a number of shows about Cauda Equina recognition, and in particular the new national guidelines, which are the Get It Right First Time pathway. And we had some really good advice, and apologies for banging on about this yet again, because I know I do it quite a lot. But we had some great advice from an osteopath, James Booth, who's worked at the Queen's Medical Centre in Nottingham within their surgical team as an osteopath. And he said, if you've got someone with Cauda Equina, possible Cauda Equina syndrome symptoms, then you call the hospital and ask them to page the on-call spinal fellow, and you ask him or her, and they will have the team ready when the patient gets there, as opposed to the patient who gets to A&E, and A&E just sometimes don't know what to do with someone who you've said is possibly Cauda Equina, which is sad.
Yeah, and I think those guidelines, Prof. Briggs has sort of been a big driving force behind GIRF. Those guidelines, and they've been endorsed by the British Association of Spinal Surgeons, BAS, have really empowered people, because they say that you need to have 24-hour MRI scanning available at centres that treat this, which, and now that referrers know this, and doctors know this, they can sort of say that actually this is a treatment, this is the diagnostic capability that we need. Interestingly, you don't actually need 24-hour scans. You can, these sort of emergency cases, what you can do is you can make them semi-routine. So at hospitals I've worked at in the past, they'll have a slot at 7:30 in the morning and a slot at 2 p.m. in the afternoon dedicated for possible cauda equina.
Right.
And it's a bonus if they don't have those scans to do, but it means that patients aren't waiting all day for a scan. The scan's then done at 8 or 9 o'clock at night, and you're operating at midnight. And that used to happen during my training up until probably the early 2010, 11, 12. I think, why am I doing this case? This patient got to the hospital at 8 o'clock in the morning. They were in A&E for X amount of time, then waiting for a scan. Why am I doing it at 1 o'clock in the morning? If we'd worked that process better, we could have been doing it at 4 in the afternoon or 6 in the evening.
With less risk of adverse outcomes for the patient.
Exactly.